evening. You're watching PBS 39. I'm your host, Tony Kayumi, and this is Healthline Women's Health. Our topic of conversation this evening is vaginal birth after cesarean section, and our guest experts are Drs. John Drake and Geoffrey Cly. I want to thank you both for joining us this evening.
Thank you.
Thank you.
Now, this is a call-in program, so I do want to let you know that you can call it at any time throughout tonight's show to ask any questions or share any comments that you might have about the topic. If you could start us out by telling us a description, so to speak, a definition of vaginal birth and cesarean section.
Okay, I'll talk about vaginal birth. That's an age-old method of delivering baby from mom's womb to the outside. It involves a labor process where the cervix, the doorway to the uterus, opens up over time and baby comes through slowly but surely and is delivered.
And so the difference with the after cesarean section is once the patient's had a C-section for various reasons, will it still work without having any problems, any rupture or difficulties with the uterine scar from the previous incision? And will it be successful and safe for mom and baby?
Can we touch upon some of the reasons why a woman might have first needed that first C-section?
Sure. Different reasons, 100 under the sun. So just a few of the most common ones could be size of the baby, position of the baby, could be size of the mom's pelvis, too small or shaped a little bit differently, and the baby can't fit down. And sometimes it could be preterm, a breech presentation, or even infection causes.
What are some of the benefits of having a vaginal birth after a C-section?
Benefit-wise, if you think about what a cesarean section means, it's an incision in the belly, somewhere about 6 to maybe 8 inches long, above the pubic bone, which is called a bikini cut in lay terms. It involves going down to layers through the abdominal wall, down to the uterus, peeling the bladder back from the lower part of the uterus, making an incision in the uterine muscle, delivering the baby, and then sewing everything on the way back up. So that's always, in my mind, considered a major surgical procedure. It has risks, such as bleeding and infection, injury to pelvic organs like bowel and bladder, sometimes poor healing, sometimes bleeding to the point where you need a blood transfusion, and that has risks of things like hepatitis and HIV. Going through avoiding that process, if possible, avoids a lot of that problem. There's less blood loss, less risk of infection.
Now, in regards to the benefits of a C-section after a vaginal birth? I'm sorry, pardon me, a C-section after a C-section.
A lot of times when you've had a C-section, many women may not be able to have a vaginal delivery. Could be their size of the pelvis, could be they have a history of very large babies. And so the other benefit is because of that scar on the uterus where that incision was from the previous time, it is a little weaker, so it doesn't contract or expand as easily. And one of the risks we're talking about tonight is what if that scar opens up during the labor process while the mom's pushing or before she's pushing, and what's the likelihood that we can detect that, intervene, because when that opens up the baby loses oxygen because of the opening and the interruption of the blood flow.
And what is the percentage of that occurring?
It's what we used to think was maybe less than 0.5% has actually, the newer information is maybe 1 to 2% of the uterine incision letting go during labor if they've had a prior cesarean section.
And what might make it more likely to happen in some women and not in others?
Number of reasons, again, from size of the baby, whether the mom's being induced, meaning her labor didn't start on its own, whether she's past her due date, usually those babies are a little bit larger, the type of incision she had the first time, and then the medicines used to assist with contractions such as Pitocin or prostaglandins or cervical ripening agents. Some of those are not safe and some of those could be safe.
Now, you mentioned depending upon the type of incision. Can you go a little further into that?
Sure.
Well, the most common incision that we use is what we call low transverse. That's in the lower segment of the uterus, and it's sideways. It does not involve going vertically up into the top of the uterus at term is the big piece of the muscle that pushes the baby out. when you get down to the very low section of that uterus, it's much thinner and it's not the contracting portion, which is why it's felt to be safe to allow labor again. If you go vertically, and there's an incision called a low vertical incision, it does not, it's vertically, but it does not go into the big contracting muscle. And then finally there's what we call a classical incision, and that's just taking that big uterus and slicing it almost in half in the front side. And that is a very unstable incision, no matter how long you give it to heal.
Now, in regards to the changing styles that are being used, was one used more in the past versus what's being used now?
That's a great question. In the past, probably in the 80s, not so much in the 90s, a vertical incision was the common route of entry for an emergency situation. Most people can have the baby delivered within 1 to 2 minutes with a vertical incision in the 80s and earlier. Most of us have been trained, who've been practicing since the 90s, were trained with the bikini cut. So we now have the same accuracy and speed in an emergency situation, because every second that baby's not getting oxygen, if you're in that type of situation, is not good. So we want to get in there as fast as possible. So most of the time when a woman has a bikini cut on the outside, she also has that bikini cut on the inside, which is the incision type that could be allowed to have a VBAC.
So then the idea of the bikini cut really wasn't just cosmetic so that it's hidden by the bikini line, it actually is a safer cut.
It's
exactly.
a very low cut.
Yes, yes.
We do have a caller on hold, so we're going to go to the phone lines
Great.
where Nan's waiting for us. Hi, Nan.
Great.
Hello?
Would you like to share your question or comment? Do we still have Nan on line 1? Okay. We may have lost the phone call, so hopefully she'll call back. In regards to surgeries and C-sections in general, a lot of people hear conversations, read articles, and hear it on the news about the incidence of C-sections rising in our country. Why is that?
The incident used to be around 5% up to about the 1970s. We got newer technology, we started looking at different things. We tried to reduce the risk of cerebral palsy in babies. That initially was felt to be a labor event. We got electronic monitoring for babies, and we could say, boy, this baby doesn't look good, we need to get it out, rather than what used to be monitoring every 15 minutes for a short period in active phase labor while they're dilating, and then every 5 minutes in the pushing stage. Well, now everybody's monitored basically throughout labor, so we started seeing that, you know, babies that didn't look good were going to get operated on much faster. We also got to the point where we stopped using forceps quite so much. There were a big change in forceps. Those are the metal devices you put on the baby to rotate it around and bring it out. Well, those have associated risks of injuries. So people stopped thinking about doing that so much. Plus, we used to deliver breech babies pretty readily. And now we know that babies can get caught, so we don't do that anymore. So the legal environment changed a lot, and the C-section rate went from about 5% to about 26% from 1970 to about 1985.
In addition to what Dr. Drake's explaining, the health climate and the maternal situation has changed some also. We have a lot different health styles and lifestyles now. We have a lot more fast food, a lot less exercise, more diabetes in pregnant women, and a lot of that increases in the size of the baby. Also, the risk to the mom during labor for problems such as a shoulder dystocia, meaning the head would come out, but the shoulder gets stuck because it's a large baby, but the mom's pelvis size hasn't changed. So those are some other reasons why the C-section rate has gone up. And then honestly, as we hear in the news every day, our friends, the trial lawyers, now I have a lot of lawyers in my family, so I'm going to be cautious when I say this, they're great people, but there's a higher expectation upon if something should happen during labor or during delivery, that a lawsuit's going to come. And so some of that is defensive medicine, not taking any gambles or risks, which were taken when we were born in the 70s, 60s, and 50s with forceps or breech deliveries.
I think we definitely do have a more litigious society. I mean, that's shown in the number of suits that are being used in malpractice cases and things along those lines.
Another thing that's changed is that people, women are changing their views. Their lives are busier, and they don't want to go through an 18 or 24-hour labor process. And when I was in training in the early 90s, somebody who said, I don't want a vaginal delivery, I just want to go to C-section, having never delivered a baby before, we would say that's not happening. Nowadays, you have women that are saying, well, I don't want a labor and I want a C-section. And even in the last 10 years in Allen County, we've discussed this in our OB/GYN department meetings, and you see more and more patients saying, I just want to come in, I want that baby out in about 20 minutes, and I'll go home in 4 days and it'll be over. I won't wait. So you see a rise in elective cesarean sections, and that's, unfortunately, there's problems that occur with that. But that's the way our society is right now.
Yeah, we've become a society who expects and desires convenience, and also we've become a lot better technologically. Our medicines have been a lot better. So in addition to what Dr. Drake was saying, a C-section outcome or the chance of a woman having a problem is a lot less. Most women do very well with C-sections, whereas in the 60s, 50s, 70s, there were many more infections and many more complications. So surgery results have gotten better. Women are doing much better. And so that's where they now have that option and want that option to have that C-section. Let's have an easy delivery. Let's plan it. Our kids are in school. I don't want to have the risk of pelvic prolapse later or a large incision in the vagina.
We do have a caller on hold, so we're going to go to the phone lines where Maggie's waiting for us. Hi, Maggie.
Hi.
Hello.
Feel free
Hello.
Hi. Share your question or comment if you'd like.
Yes, I have a question about mandatory C-sections. When I was pregnant in April, I was informed that I could not have a VBAC and that Indiana was no longer doing them and I had to have a C-section. And my question isn't there associated risks with C-sections along with a VBAC, and can they mandate you to have a cesarean?
Well, that's a great question, Maggie, and I'll touch on some of the risk of C-section, and I'll have Dr. Drake touch on the vaginal delivery. C-section, yes, has a higher risk to the mom, but with a lot of the advances, we have less chances of those abnormal or bad things happening, such as maternal death. Certainly infections happen, but we're usually able to take care of those with IV antibiotics. The other thing in Indiana, if we wanted to do a VBAC, we need to make sure we have the surgery staff, the anesthesiologists and physicians present in the hospital, which could have been part of the reason you were mandated not to have that VBAC. Dr. Drake, I'll give you the vaginal birth part of that.
I'd touch on why your doctor said you're not having a VBAC, and a lot of it has become because the doctors are also protecting themselves against litigious situations. And the problem with that is that, you know, if you say I'm going to make you have a VBAC, then and something goes wrong, it's a very bad situation for everybody involved, including the doctor. And there's a lot of doctors in Allen County that will no longer do vaginal birth after cesarean section. Dr. Cly and I are in the same group, and we're 8 doctors, but not everybody's going to do a VBAC. So your doctor may have made a medical decision that it was not safe for you to consider a trial of labor, or they may have made a medical legal decision saying, I'm not taking that chance, so either get a repeat cesarean section with me or find somebody else. So unfortunately, that's the way things are going.
Yeah, also, Maggie, the way we work, our group is we have 8 doctors. Myself and another doctor don't do VBACs, and we might get into that in a little bit. I just don't feel the risk is worth the benefit. I've seen some tough situations. Usually what we try to do is offer, though, to the patients. If a patient comes to me and would like a VBAC, I'm honest with her and say, you know, I really don't feel it's the right thing. But at the same time, it's still indicated medically, and there are many people who have a successful VBAC. So usually I'll have them see Dr. Drake or another physician in our practice who does the VBACs, because it's still important, since it is an indicated and justifiable procedure or thing, to give patients that option.
Maggie, did you have any follow-up questions about that?
I don't think I did about that. The only real quick question I had was, is that more of the doctor's decision, or is it an Indiana decision or hospital decision? They informed me that it was DuPont who said I could not have the VBAC.
The hospitals are wrestling with this problem too, and the hospitals are looking at what's my liability if something goes wrong, and the hospitals are trying to protect themselves. There was a time from about 1985 to 1996 or so where managed care in the hospital says, you know, we're going to make people have a trial of labor. It costs us less money, there's less risk and all this stuff. Well, then we started seeing a little bit increase in the risk of rupture of that the uterine incision, and the hospitals backed off. What they're swinging to now is a lot of the hospitals are saying, we don't want you to do any VBACs in our hospital. It's too much of a risk, and essentially they're saying we cannot get the anesthesiologist to be available that much. We can't get an operating room moving fast enough, so we don't want to take the risk. So yes, that's true. And this year alone, Parkview Hospital has debated, the department has debated hotly about VBACs and what the rules are going to be, and it's a lot more stringent than 10 years ago when I got here.
Just so we don't throw DuPont under the bus, it is a very good hospital, and I'm on one of the committees there. They've changed some of the guidelines for the VBACs, and we've basically tried to say at DuPont, in order to ensure safety for the patients, that should a woman come in who wants a VBAC, her physician's got to be in the hospital, immediately available. The anesthesiologist has to be immediately available, as well as the surgery and the operating room staff, so that if something should happen, and remember earlier I mentioned that the lack of oxygen, or a problem is a lack of oxygen to the baby, and every second counts. We want to be able to get that baby out within just a few minutes, and if people are driving in from home, then that's too long. And so that's part of the change that's happened at DuPont, but certainly they still perform VBACs. It could have been, though, that your physician wasn't able to be immediately available because maybe that physician has another office or two offices and had to be at another location when you were in labor, or would have been.
Thanks for your call, Maggie.
Thank you.
Now, you had both mentioned that you have, your own personal feelings about these procedures, and that's why you have sometimes elected to do the VBACs if the situation allowed it, and whereas you do not. So could you talk to me a little bit about why you both feel strongly about the way you do?
Mm-hmm. Sure. I came from Ohio originally, and Miami Valley Hospital is a great hospital, and we have a residency teaching program there. So we had multiple physicians, anesthesiologists, and staff available 24 hours a day. Deliveries occurred all the time there. And I've found that several times during my training, we've gone for that emergency C-section because someone's patient was crashing, and we got the baby out in just a few minutes, but another minute that baby could have been brain dead because it just wouldn't have made it. And I feel like here in Fort Wayne, where the staff is there, we need to make sure that we have that instant availability. And recently the hospitals like Parkview Hospital is making sure that they have anesthesia in-house, and they have the doctors around, and they're really becoming strict on the policy. So they've made some great changes in a positive direction. But before now, I didn't feel like I could have that baby out in 2 to 3 minutes. And that's what also the insurance companies are recommending, that if you can't get the baby out in 3 to 5 minutes, they may not cover you in case there is a lawsuit. So the medical legal thing comes into play, and not only just for the risk of the baby, but also the risk to us and our ability to work from a lawsuit.
And your feelings?
The patient has to be chosen properly. A patient who is 39 weeks with a closed hard cervix who wants a VBAC is a long way from getting something done. The patient who comes in at 39 weeks and their cervix is 2 to 3 centimeters dilated, the process is already happening, I'm willing to back off and try an attempt at a vaginal delivery. We do a lot of inductions for our babies. A lot of women say, I want to be induced, I can't stand it anymore, get this baby out. And that with a VBAC is not a great idea. The medicines that work so well for a woman who's never had a cesarean section can be a hazard for the woman who has had a prior incision. So I look at the factors with the patient. I kind of get a feeling what kind of relationship we have. and I make an assessment. I mean, if this baby is twice the size of the last one, no matter what, it's probably not going to go. But I also look at the fact that the success rate of a VBAC is about 60 to 70%, which is a wonderful success rate, and that's meaning they avoid the cesarean section. And that hasn't changed, that success rate. So I look at all the factors and try to decide what's best. I have a lot of patients, we talk about it, we talk about the risks, and they go, you know, I don't want to do that, I want a C-section. And I go, and I tell them, that's fine. At least we've talked about it.
Are there also women who also feel strongly about really wanting to give birth vaginally, that it feels like something that they want to do, emotionally speaking?
There are a lot of women, absolutely, that want to do that. And if I think that's unsafe because they've had a cesarean section or two, then they need to find somebody they're going to have to do that, because doctors don't want to be pushed into a corner any more than patients being told, this is all I will do for you, you will do this. So sometimes you decline and just say, no, that's not a safe thing.
Yeah, well, I will say Dr. Drake does an excellent job of he doesn't back himself in the corner. He's not afraid to say, you know, we thought this was a good idea, but right now at the moment, it's not a good idea. And that's extremely important in a physician, because you've got to be able to adapt and change to what's occurring in labor or in the process. So I have to give him a lot of credit for that. I've seen some issues with the babies who, because the mom wanted the VBAC, and I can't say whether they were the right choice or not because they weren't my patient, but I was there on the backside sometimes, or in labor and delivery when these emergencies happened, and some of these kids are brain damaged, and I just feel I can't justify that as a doc to take that risk for of having a vaginal delivery for potentially having a brain damaged infant. And if the risk is 2%, an analogy I use, and remember I am biased against the VBACs, is, you know, if you're flying out of Fort Wayne and 100 flights take off that day and you're told 2 of the planes today are going to crash and burn, we just don't know which 2 it's going to be, and we can't stop them or help them before they crash, what do you want to do? And I think maybe I'd want to drive that day. That's how I look at it.
We're going to go back to the phone lines. This time Joan's waiting for us on line 1. Hi, Joan. Would you like to share your question or comment? We still have Joan on line 1? Okay, we're going to move to line 3 where Christy's waiting for us. Hi, Christy.
Hi.
Hello.
Hello, Christy.
Would you like to share your question?
Yes, my question is, I delivered my first son almost 12 years ago, and I had an epidural, and I had difficulty then delivering him, and the doctor used a vacuum to deliver him. He had a bump on his head that was supposed to go away within 2 weeks. It did not. He had it for 9 to 10 months. Every time I would ask about it, when I went in for a well baby checkup, they were like, oh, it's fine, you know, it will go away eventually. Well, he ended up with one side of his head flat from where he favored the other side, and it never went away completely. It got better, but it just changed the shape of his skull. And he's had a lot of problems with learning disabilities, and I just wondered if it was possible that was a head injury.
Thanks for your call, Christy. We have about 2 minutes left to answer.
Okay. Sure, it's an excellent question, Christy. And I think what you're alluding to is, did he have maybe a skull fracture or hematoma from the vacuum? Certainly, sometimes I know hematomas can happen. Forceps would more likely to cause a skull fracture. And I don't know the situation when you were delivering. We usually try to reserve those type of procedures until it's really an emergency or urgent situation where the choice is either perform a procedure to deliver the baby because it's not receiving oxygen and it's going to have serious problems if we don't deliver that baby right away, or and we don't usually like to use those at all unless it's not an emergent situation like that. So I'd say you'd have to really look at everything that happened, and I don't know how to answer it completely, but I do hope that he does very well.
Anything you wanted to add?
Doing a vacuum is a lot less aggressive a procedure than doing a forceps, and there are requirements for where the baby's head is at. It's got to be way down there at what we call +2 stations, so that when mom pushes, you see the baby's head. That's very low. Going through labor, a baby's head, the skull is not fused, so those bones override. And that's normal because the baby has to come through the canal to do that. Sometimes you'll get something called a cephalhematoma, which is Dr. Cly was saying. That's a blood clot under the scalp. Most times it's called caput succedaneum, which is just fluid collected, and it happens with or without the use of a forceps or a vacuum. So there's a lot of different factors, how many times the baby was pulled. Some babies come through the pelvis, or they've been in the pelvis in the womb so long that their head is somewhat misshapen, and whether you do a vacuum or a forceps or not, that can happen. So
I want to thank you both so much for being here. We're actually out of time. Do appreciate you joining us here at PBS 39. Coming up next week, we're going to have breast cancer treatment update with Dr. Laura Morris in the cancer care segment. And that will be coming up on PBS 39 on the 27th. It's going to be body contouring, liposuction, and tummy tucks with Dr. John Mancull. Have a great evening. You're watching Healthline.